I didn't die, so we're good. I did have the flu, though, which if you haven't done that in a while, it's a fun trip. Don't recommend. So as I understand it, you guys have gotten through all of the vertebral column so far, right? So we just have to do ribs and maybe sternum if there's time. Yeah, since it comes up in clinical. So we'll focus on ribs for the most part, and we'll throw in sternum at the end. So
ribs is
for fun.
On our final.
Yeah, ribs are on your final. Sternum is not, but the sternum does come up in your clinical rotations apparently around here. I had only ever done one sternum in my time in the ER, but apparently they do them here in California. So we're going to learn sternum. Okay, so who could tell me the breathing instructions for ribs above the diaphragm? Great, we're killing it already.
Let me open my book first. Let's go to ribs.
Killing it.
Above?
Inhale. Inspiration. Yes. Why?
For air. Something air.
To decrease the density, right? We're making it easier to penetrate so we can get a better, more clear image of the ribs that are above the diaphragm. Okay? Couple of quick thingies that are probably going to be really difficult for you to conceptualize, but I'm going to do my best to make it really easy for you to conceptualize. When you are imaging the ribs, where the pain hurts, or where the patient hurts, where the pain is, matters. Okay? For example, if they are hurting in the anterior ribs, do you want to do an AP or a PA chest x-ray as part of the series?
Whatever one that focuses on that section.
That only partially answers my question. Thank you, April. If they're hurting in the anterior chest, do we do a PA or AP chest? PA. Why? Absolutely. And if they're hurting in the back, we do AP. We put the part that hurts closest to the film. Okay? So that's rule number one. Okay? Rule number two, for pain in the anterior rib cage, we want to worry about which way we're rotating the patient with regards to where the vertebral column is in relation to the pain. Okay? So for example, if they're hurting here, this is the universal symbol for pain. If they're hurting here, if we rotate them this way, we've now put the pain over the spine. Do we all see that?
No, I didn't see the rotation at all.
Come right here. Stand right here. Patient is 45 degrees. If we do an RAO incorrectly for this pain that's in the right anterior, we have now put the pain over the vertebral column.
Okay, I understand.
Got it? So we want to move the vertebral column out of the way so that we can see the pain. Okay? So we're going to actually do an LAO for right anterior pain. Okay? And the opposite is true for the other side. To get the vertebral column out of the way. Because if the patient has a fracture here, it's hard to see with the vertebral column in the way. Okay? If they're hurting in the back, well, you all get it. Here's where the pain is. Okay? We're still worried about which way we rotate the patient. So if they're hurting here, do I do this oblique or do I do this oblique? Why? And it's rotating it out of the way, right? Okay? So we're going to, if they're hurting in the back, we're going to put the part closest to the board, okay? They're hurting on the right side, we're going to do a right posterior oblique. They're hurting on the left side, left posterior oblique.
Same thing with the pain with IR.
Same thing with the pain, okay? And to help you remember, it's kind of similar to the imaging fundamentals for the frontal or the anterior pain because we're still moving the spine out of the way. It's just not as much of an issue for posterior pain, okay? Does that make sense? How am I doing? Great. All right, so quick review. I'm hurting here. What is my series that I'm doing?
PA.
Yes.
And then the oblique on that side.
Which is? This would be an RAO. Clear the spine, okay?
Wait. Okay.
You can also, I've got one more little trick. Cross your thumbs. Circle your hands like this. If your pain is in the front here, if I rotate this way, I put my spine in the way of the pain. So I want to rotate it away to get the spine out of the way so I can see the pain on this side. Make sense?
So if the pain's in the front, you're going to go to
The opposite oblique, the opposite anterior oblique.
Okay, well, we'll talk about it later.
We're not going to talk about it later. We're going to talk about it right now because we're here.
So for clarification, right side is hurting. You're exposing your right.
You are doing the left anterior oblique. Yes. Yes. If they're hurting here, I'm getting the spine out of the way. RAO. If I'm hurting here, RPO. If I'm hurting here, LPO. Okay? Let's put some light on it so maybe that helps too. Shadow graph. I'm hurting here. If I go this way, I can't see my pain now. Spine's in the way. So I'm going to do, well, actually, let me turn around and actually get it right. Hurting here. If I do the right anterior oblique, the spine's over my pain. We all see that, right? So I'm going to do this oblique to open it up so I can see it. Okay?
But so the pain side still going towards the IR, just the opposite.
It's still the shortest distance to get that pain visualized, right?
I think that's it.
Pain here in the right posterior oblique. I can still see the pain or the area where it's fractured, right? Potentially. Make sense? Questions? Drill that in your head because I promise you it's probably going to be one of the hardest things that you can learn from this entire 8 weeks. People get very confused by it. If it helps you, use the skeleton. Okay? What is your breathing instruction for ribs below the diaphragm? Expiration. Okay? So ribs above the diaphragm, the series is usually includes a PA chest. Why does it include a PA chest? Why would we do a PA chest on a rib series?
Because they do it for everything.
Come on, guys, think. Why would it be important if an emergency room patient comes in for us to do a PA chest on someone who may have fallen and fractured a rib?
You can see everything literally, like you see.
We may have fractured a rib. Ribs are sharp when they fracture. It could have punctured a lung. We're looking for a pneumothorax. Okay? So PA chest is part of a rib series. Then we do the individual rib images. Okay? You'll focus down on the unilateral side where the pain is. Okay? Make sense? Questions? He can't believe it.
But,
Looks like one of my cousins in North Carolina.
But it says posterior pain when we do AP.
Yeah.
Chest series.
Yeah.
So then if it's an anterior rib series or the pain's on the anterior, we do posterior.
The pain, wherever the pain is going to be closest to the IR. So, I'm having pain under my breast area, you're going to do a PA. If I'm having pain in the back area, radiating to my back, then you're going to do an AP.
Okay, so that's the series that we follow for pain-wise.
Just think of, if for our purposes for the lab, you're not, as far as I remember, going to have to do, which I haven't looked at your lab notes for this week. Does it say PA chest on it?
Yes, and it says AP also for the just goes based off of pain.
Got it. So that, I think, is referring more to imaging for the actual ribs. In your clinical rotations, though, a PA chest will be part of the routine. Yeah.
Regardless where the pain's at.
Absolutely.
That just has to do with lung.
That just has to do with lung and heart, like any other chest X-ray would. Okay.
Okay, gotcha.
Usually say PA chest. Your order will say PA chest with right ribs.
Okay.
Questions?
And then you do the right ribs or whatever the
Yeah, so you do your
situation
PA chest, and then you're gonna
do all that.
Whatever. Yeah.
Okay, gotcha.
Questions? I missed you guys. Welcome back. All right. I say welcome back to you like I'm not the one who's been missing. I know you guys have been here. It's been me. Slack ass over here. All right. you guys can take some time, excuse me, to work on the ribs. My recommendation is for you to break off into 2 groups and suggest an area of pain for each other. I'm hurting here, I'm hurting here, I'm hurting here, blah, 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 okay? Actually, I probably should show you the imaging for that first, and not just where the pain is. I'm out of practice, Nor.
Tell them to get it together. Where's your puppy?
It's right there. Had to replenish my electrolytes first. Oh, great, there's one in there. Okay. If you can image a chest x-ray, though, if you can dodge a wrench, you can dodge a ball. I'm kidding. If you can image a chest x-ray, you can image ribs very easily. So may I have a patient, please? Come on over, Dimitar. Let me grab my markers. So for our purposes, Nor was putting up Christmas lights and fell and hurt her right or her left posterior ribs. Okay? We're going to go with it. So put your back against the board for me. What is your centering for AP ribs above the diaphragm? Bam! Step this way a little bit for me.
So you're doing an AP chest?
We're not going to do that
Oh,
because we already know how to do a chest x-ray.
okay.
But we are doing AP unilateral ribs. And collimate down to the side, okay? You want to make sure you've got the patient nice and I keep moving you back and forth, I'm sorry. You don't want to have the arm in, obviously we're not looking at the arm, right? But you want to make sure that you include all of the rib on that side, okay? So you want to have the light spilling off the side a little, okay? And your collimation to kind of overlap the opposite side just a hair. Okay? Breathing instructions for this, take a deep breath in and hold it. Don't move, don't breathe. Okay? And breathe. Questions?
It's still T7, though, it's not.
T7 is the centering, yeah. Okay? Ribs below the diaphragm, super easy too.
Sometimes you don't even need to get the lower.
That's true.
They're like, if you get it over one, then you don't have to.
And you'll notice that when you see the image.
Yeah, you see the image and you see your last rib and it's all perfectly clear. Usually like the tiniest patients, you can
Yeah.
get the whole body.
Oh, okay.
So if someone like Nor did fall off a ladder, make your job really easy. I feel like that lines up. And what is your centering for ribs below the diaphragm?
Midway between the X something, XIQ, yeah, and the 12th rib.
Okay. And how do we find that?
You find that by.
So what I'm going to do is ask my patient, can you touch the bottom of your breastbone for me? Great. And lower rib margin is there. So I'm going to center right about there.
Clover Learning has got nothing on you. She should say that.
My cousin on Clover Learning.
Breastbone and down. Like,
Okay. And for ribs below the diaphragm, take a deep breath in, blow that breath all the way out, hold it out, don't move, don't breathe. And breathe. Okay? Questions? So rather than, especially if I'm a dude on a female patient, I'm not going to reach and try to find, their xiphoid process. I'm going to have them find it so I can use their finger as a localizer, and then I'm going to reach for their lower rib margin myself. Okay? And then just kind of split the difference here. Okay?
For patients that don't know anatomy, you just ask them to point at the bottom of their chest.
Just point at the bottom of your breastbone. Most people know what their breastbone is, right? I would say. least it's worked for me for 20 years. Other questions?
And then with her facing this way, it's considered an AP or PA?
It is, because the ribs below the diaphragm don't really curve forward like the rest of them do. So the ribs below the diaphragm is just the AP. Okay. Again, on most people though, if you can capture the entire ribs on the oblique, that is preferable. And honestly, not difficult, I would say, most of the time. Yeah. Yeah. Yeah.
So then doing PA, just flip them around.
Mm-hmm.
Okay.
Yeah.
And then doing it oblique is just rotate the same.
45
The
degrees.
same, that's what
Yep. Depending on where the pain is. Okay?
Right, that's.
Oh, I probably didn't. I'm sorry. I'm so out of practice right now. My brain is foggy. For the oblique, same. Sorry?
I was like, I was just asking. I didn't.
No, you were right. I didn't show you how to do this. So we're going to center the same as we would for a chest. I have a very patient patient, thankfully. She's hurting still in the left posterior. So what we're going to do is have her reach this arm up. How do I want to do this? Keep that arm out and turn this way, right? See how out of practice I am with ribs too?
Posterior.
This is posterior pain.
Posterior pain would make it LAO.
No, LPO. Okay?
Yep.
It will become clearer.
I know.
All right, you can relax. Thank you. Questions?
This is the part where you guys say it's easy and you know.
It is easy. It's also rare, but it's easy.
Ribs?
I would say so. But I also think, nor surprised me it said that the clinical sites are doing sternums. So
Yeah.
everything's out the window. Okay. Questions? Oh, I gotta turn some air on. Anything else?
Sorry. Are you scared?